So we have two more speakers. We have Bex Lathey. Bex is going to start, give us a talk on Yorkshire and Humber critical care aspect of MEaCC. Now Bex, many of you will know, she's a consultant in intensive care and in anaesthesia at Leeds, and she has an interest in MEaCC critical care. She's an interest involvement in the MEaCC and maternal medicine networks, and she's currently leading a regional multidisciplinary committee working to deliver education and resources for staff caring for the critically ill peripartum patient. Now, Bex, where are you? Oh, she's there. Doing great. I'm doing great this afternoon, everybody. Stick with it.
I don't want to take this.
No, Bex is being very kind. I'll let her have the podium. Thank you.
Thanks. Thanks for the intro, Sarah. It's great to see so many people here that I know. The joy of being a new consultant is that I've recently worked all around the region, so it's great to see lots of different faces here from across Yorkshire. So I really want to follow on from what Claire's saying in talking about an update on where we're at in Yorkshire and within MEaCC in trying to deliver some of that education for our critical care nurses. So as we've alluded to already, ideally, we'd love all of our women to be looked after on delivery suite, remain with their babies under the expertise of the midwives and obstetricians, and even better, we could look after some of them in enhanced maternal care areas. But unfortunately, there are a proportion of women who do need to come to critical care, and it's time to now think about how we optimise their care to make sure that we're giving the best quality and experience to them across the region. Thanks to Viv, we've got some data from the latest MEaCC published data looking at how many people do actually need to come to critical care, and it's about 4%. So looking at the MEaCCs 1 to 3, it's in the region of 2.5% to 5% across the board, so fairly consistent in the numbers who need to come to us. And the reasons for coming, as we've spoken about earlier, are that about a third need some additional monitoring that either can't be provided within the enhanced maternal care area or in hospitals that don't have that facility yet. About a third actually needs some proper organ support, so level 2 and 3 organ support, and unlike Nottingham, most of our enhanced maternal care areas are providing level 1, which is sort of monitoring and enhanced nursing. But when we talk about level 2 or 3 intervention, we're talking about support for organs, so respiratory, cardiovascular or renal support being the primary functions. And about a third of people need specialist intervention, so that might be that they need to be in a neurosurgical ICU or a cardiac ICU. And to break it down a little further, I'm just going to show you some of our Leeds admissions over the last 12 months. And the reason for putting this up there is to show that really we're all dealing with similar pathology regardless of the size of our critical cares or where we are in Yorkshire. So we do have a proportion of our patients who need specialist cardiac beds, so our maternal cardiac patients, and we also have a proportion who need neurosurgical beds. But the vast majority of our admissions, even in LTHT, are relating to things that you will see on whichever critical care you're working on. So hemorrhage being our main one. Within other, a couple of those patients were severe hyperemesis with electrolyte derangements. So really obstetrics heavy problems, not the sort of tertiary problems that you would expect us to have in Leeds, like cardiac disease. And if you look at our numbers, so I know Claire was saying they had actually quite a few more interventions from their critical care team. Here we're having about 2 a month admissions to ICU in LTHT, and we've got 5 ICUs, each with 15 beds across site. So you can imagine for our nurses, similarly, they're just not seeing these patients frequently enough to have the confidence to look after them. So as we've spoken about, GPICS does have a section on maternity, but it's actually quite short. There are only 8 points in there which tell us the recommended standards, and they really relate to how accessible other services should be, so that we should be able to, for example, have the kit to perform a perimortem section or resuscitative hysterotomy now immediately, and have access to neonatal services. But what it doesn't tell us about is the training and education that the staff need. So, what difficulties do we have in the region? Now, I think we've all just seen an amazing piece of work from Nottingham that we would love to emulate in Yorkshire. But most of our trusts in Yorkshire haven't been able to develop that sort of education package yet. And so what we're seeing is that on canvassing our nurses, they really are unfamiliar and unconfident with managing anybody in the peripartum period. The majority of our nurses don't have any experience in obstetrics, and in some cases, even now within Yorkshire, the only way that they can get a bit of expertise from a nursing side is to put the nurse who's recently been on maternity leave herself with the postpartum patient in the thought that they might have some idea on what's normal in the antenatal and postnatal period. And I know it's funny, but it's also pretty scary that we can be working in big tertiary hospitals and our staff just don't have the training to look after this cohort of women. And I think a lot of the other issue we have is that when people come to ICU, there's the expectation that, oh, they're on ICU now, they're safe, they're in, they've got one-to-one care, they've got lots of medical expertise. But the obstetric and midwifery aspects of it can be difficult to access once you get onto ICU. If you're in Bradford and you're in a different hospital site, it's actually very difficult to release a midwife to come over to ICU every couple of hours and maybe monitor antenatally or keep an eye on postnatal checks. And we're finding similar things in Leeds. And similarly, as Debbie's already alluded to, our medical workforce also don't have now the expertise in obstetrics. So those of us who do anaesthesia or obstetric anaesthesia do have that interaction with the obstetric teams, but about half of our intensive care trainees, our resident doctors coming through now, are not twinned with anaesthesia. They're either single-stream intensivists or they are doing intensive care medicine alongside A&E or acute medicine, and they may not have seen an obstetric patient since medical school. So although you think they're in a place of safety with nurses and doctors who would know how to handle this, they actually can be reasonably isolated from the obstetric care that they need. So how are we going to tackle this in Yorkshire? And I think what we've found from the last 10 years of MEaCC projects is that working together as a region is incredibly successful and an incredibly useful way of working, because all of our intensive care units, regardless of how big they are, will need to deliver a similar sort of training. So not exactly the same, because the needs of each unit will be different, but we'll all need some degree of training and some degree of resources to try and make it safer when women are admitted to us in the peripartum period. So at the moment, some of our units around the region, I'm looking at the York table over here, have been doing some in-house training, so similar to the training that's delivered in Nottingham. They've been able to do single study days or half study days. This one was targeted at the outreach team and was led in-house. And that was really to give a broad overview of some of the changes in physiology to expect in an obstetric patient and an insight into some of the obstetric-specific conditions or complications that might bring someone to ITU. And we were lucky enough on this day in York to have input from our senior midwives who came along and spoke to the outreach nurses about the importance of skin-to-skin, psychological impact of coming to ICU, how to encourage breastfeeding, and really created a great link between ICU and midwifery that might not happen everywhere around the region. But what's the point in doing this individually, so each unit doing all the same thing? In York, at the time, there were people who had a maternal critical care interest, but in some of our ICUs around the region, there aren't any intensivists who have a proper maternal critical care interest, and they maybe that we just can't access this information. So on the knowledge of that, MEaCC team spearheading a collaborative approach to try and deliver some of this education in Yorkshire. And we're working closely, taking lots of tips from the team in Nottingham and also Newcastle to try and work out how to deliver that. We've now, over the last 18 months, developed a working group of about 30 people, and it really is multidisciplinary. So we've got anaesthetists and intensivists, we've got midwives, we have obstetricians, we have representatives from Maternal Medicines Network. We've also got 2 obstetric physicians from Sheffield, which is amazing. We've got midwifery input from all around the region. and we've also got links now with infant feeding teams and bereavement teams. So the group of us are working together to try and deliver the first region-wide study day, which is going to be happening in March. So all of your units that you work at, your ICU nurses, a small number of them should be getting an invitation to try and come along to that. And it seems like a good time for me to plug that if anyone's interested in helping us deliver that, that would be great. So what we're looking at delivering is some teaching on the medical and obstetric side. So we will be looking at hypertensive emergencies, hemorrhage control and management of that. But the feedback we got from this York day was that what the nurses really, really valued was the input from the midwives and the obstetricians. So many of our nurses don't understand what the term gestation is. They don't know that when we talk about resus status, we're not talking about blood groups. They think we're talking about CPR. They don't really know what parity is or what normal changes are to expect in that early postpartum period or even in the late antenatal period. So what we're going to be focusing on for the majority of the day is a normal pregnancy journey so that our ICU nurses have got good insight into that and what is a normal changes of pregnancy and what we should be worried about. So if you're an ICU nurse or an outreach nurse, you can say that this set of observations might be normal for my usual cohort, but in this pregnant or postpartum patient, we need to be thinking about whether this is something to worry about. So that's the education side. The other aspect that we're thinking about is that even if you provide an excellent education programme, as we've said already, you might have the education and then not deal with a peripartum patient for a year after that. So what can we use as prompts to make sure that the right care is being delivered at the time without you having to use your memory? Now, one of the things that we're doing around the region is introducing checklists for admissions when patients come to ICU. And this checklist is our Leeds one, but is very similar to the one used in Bradford and was written based on published checklist from Harrogate and our colleagues there, from London, from Nottingham and from Newcastle. And these checklists help us align with the GPIC standards, but also make sure that we've got the right people involved. So there's a couple of examples of how it might work. I'll show you a little bit more honed in on there. So we may have a patient who comes in from A&E with respiratory failure, severe pneumonia and is intubated, and there have unfortunately been situations where that woman is on ICU, heavily pregnant, and the obstetric and neonatal teams don't know that she's there. And then, should she come to deliver, we don't have that plan in place and we haven't involved the right personnel. So the first part of the checklist is to make sure that the right people are involved. And that also brings in links with Maternal Medicines Network, where we might be admitting a patient who's known to the network and it obviously know the woman very well, or it may be that we're picking up a new problem that needs intervention from the network. And so the rest of the checklist has links in with that as well. And it also makes us think about what we would do if that patient were to go on and have an obstetric-related emergency. So, for example, if our patient with pneumonia goes on and has a baby unexpectedly on ICU with little warning, we don't have any equipment for delivering a baby. We don't have uterotonics. How do we make sure that we've got the right kit there should that emergency rise? And we know that we can't keep a full labour ward on ICU, but it's about having that individualised plan when patients arrive to say, do we think it's likely they're going to have a baby? What kit might we need and who do we need to talk to about that? And so these prompts run on a daily basis for us to review the clinical situation and think about who we may or may not need as the patient's journey is progressing. The other impact that we found is that because of our infamiliarity with obstetric patients, if we did need the teams in a hurry, and unfortunately by nature of our patients being critically ill, a proportion of them do deteriorate or go into cardiac arrest suddenly, who do we ring and make sure that the right people arrive? And so in Leeds and in Bradford, we're now using bedhead alerts. So we've got a poster at the back of the bed when a pregnant patient or postpartum patient is admitted. It's laminated. This is our Leeds one, but Bradford and we have been collaborating together. And it basically prompts you to put the right crash call out or the right emergency call and tells you where you might get that emergency equipment that you wouldn't have necessarily time to ring around and find out. The other tool that we're using in Leeds is a little sticker on the easel of the chart. So every day the nurse will fill in a new sticker with today's date. And this is a little S-bar tool so that in an emergency situation, the ICU nurse who may never have experience with an obstetric patient can pick up the phone to a coordinator and give you the information as midwives that you need to know to send the right kit. So things like gestation is really important in deciding about neonatal crash calls, for example, or thinking about what you might need in an emergency. So every day that's updated with their up-to-date gestation, and they may or may not have experience with the pregnancy complication that they're describing, but it's a little tool that we can use to give accurate information. And it's really easy to do and doesn't cost the unit any money really, but it's just helping provide some of the confidence when we've got these patients in, that we know we're in an environment where it's not ideal to have a pregnant or postpartum patient, and how can we improve the safety that we're doing there. And I think ideally as a region, we're working towards sharing all of these resources so that all of the ICUs can use them, but also expanding on that. And Penny has created an excellent online platform so that we can start sharing that information, not only around the region, but also nationally going forward, to save us all doing the same work over and over again. So, in summary, where we're heading as a region is really, really exciting from a critical care perspective. MEaCC's demonstrated 10 years of collaborative region-wide working to improve the safety of women who need enhanced care, and now it's moving on to the next step of how we continue that collaboration regionally to improve the care of patients once they come to ICU. And the way we're going to do that is by delivering region-wide education and hopefully national education with collaborating with colleagues around the country. And by sharing our resources and expertise, because together we've all got a reasonable amount of experience. But if you look at each individual unit, you're much weaker than if you're looking at a whole group all around the region. So if anyone would like to help us, we'd be delighted, especially from an obstetric and midwifery point of view. And I'll leave it there. Thank you.